Thank you everyone for joining. We'll start after 2 more minutes. Thank you. Good afternoon, everyone. I am Dr. Riya Gurwal. I work as a program manager at Dakshma Health. It's a privilege to welcome each of one of you for today's webinar. We sincerely appreciate your presence and we extend our gratitude to our distinguished speakers and attendees for taking a time to join us. Dakshini and Amravati Health and Education is not for profit and a patient organization that is committed to advancing patient safety and quality healthcare. Our mission is to empower patient caregiver with right knowledge, tools, and forum to seek and access healthcare options that suits their needs and through their voices bring about a positive change in healthcare environment. One of our initiative is Patient for Patient Safety Network India, function as a broader part of Patient for Patient Safety Network Asia Pacific. Through this initiative, our advisory board that's comprised of patient organization collaborates with healthcare institutions, hospitals, and providers to promote safe healthcare practices. We are also being closely engaged with other we are being engaged with other patient safety units and are also engaged with Ministry of Health and Family Welfare for this. Our organization has been actively been working on patient safety since 2018, and we have been organized a World Patient Safety event every year. From 2022 to 2025, we have been engaged with a series of webinar on medication safety, and we have organized various word safety events with OPI, OPPI, as well as with CAHO. In 2023, we have been engaged with a series of three webinars on the month prior to the World Patient Safety Day to raise awareness about the theme engaging patient for patient safety. In 2024, Dakshma Health has been organized a series of six webinars on focusing on improving diagnosis for patient safety. In this year, 2025, we will be hosting a series of four webinars under the theme Safe Care for Every Newborn and Every Child. Patient safety from the start. Today, we gather to discuss how we can strengthen maternal and newborn care to reduce preventable and improve overall patient safety. Our objective is to initiate multi-stakeholder dialogue to, to enhance mechanism through meaningful conversation and expert insights. Uh, we aim to explore ways to improve referral pathways, diagnostic accuracy, and continuity of care for maternal and newborn. So, welcome you all for today's webinar. So, I'll start with the introduction of our today's speaker. Our first speaker for today's webinar is Dr. Sunita Ghosh. She is Officer on Special Duty, Health Niti Ayog, ex-additional commissioner in charge, Child Health, Adolescent Health, Safe Newborn Service, Abortion Services, Aspirational District Program, from Ministry of Health and Family Welfare, Government of India. Her area of expertise is pediatrician by education and has 40 years of expertise in clinic, training, and administration in government. She previously looked after several programs like family planning and maternal death surveillance and review program, various training program, etc. In ministry, she being the technical lead providing support to ministry in national level policy, program, program implementation, monitoring and supervision. She is the member of various national international expert group. At Niti Aayog, she is presently working on school health mission, anemia, critical care, comprehensive primary health care, and other health policies. Her notable contribution is many national health level guidelines, publications, along with many other ministries' publications have been released under her guardianship in child health. Her publications were various under national and international journal. She has also been involved in Maternal Termination of Pregnancy Act as well as rule, which is the key changer in accessing safe abortion services. Uh, Now, our next speaker will be Dr. Rajesh Mehta. He is MD Pediatric, FIAP, Adjunct Professor, Public Health Foundation of India. He is the former advisor at the WHO Regional Office of Southeast Asia, provided strategic advice and support to 11 countries of the region to strengthen newborn, child, and adolescent health program. He's been involved in QI, Champion, and Expert. He led and coordinated the Regional Quality Improvement Model, PO, Point of Care Quality Improvement in SEA region, and that has been introduced in other region. He has 40 years of experience in newborn and child health at countries and regional level and global level and has multiple publications. Our next speaker will be Dr. Neelam Killer. He is a chairman and department of neonatology, Center for Child Health, Sir Ganga Ram Hospital, New Delhi. Her honors were she has conferred Padma Bhushan Award from President of India in 2014. Has fellowship honored doctorate by Punjab Academy of Science, Punjab University in 2014. Her citation award for 2016 from the National Private Healthcare Business Express India, and she has Achiever Award 50/50 birth anniversary of Word Guru Sir Guru Nanak Dev Ji, organized by Government of Punjab on November 10, 2019. Our next speaker for today's will be Dr. Priyanka Tiwari. She is pediatrician and neonatologist, MBBS, DNB, and fellowship for neonatology. She is a dedicated pediatrician and neonatologist with over 11 years of experience in child and newborn health care. Her expertise lies in managing critically ill and extreme preterm infants, as well as overseeing immunization, growth, development, and common childhood illness. She has been trained in some of the India's leading medical institutions. Dr. Tiwari's bring extensive experience in advanced neonatal care, high-risk deliveries, and newborn resuscitation. Now we'll start the webinar. Over to you, Dr. Sunita Ghosh, ma'am.
Thank you. Thank you for inviting me and making me part of this webinar series virtual and in presence of such luminaries. So I'd request if you can share the presentation from your end. Uh,
Yes, ma'am.
Patient safety and especially maternal and neonatal safety is very close to my heart, and I'd be very glad to share some thoughts about it with all of you. So, next slide. Yeah, this is all about how how we can make our the present scenario context for mothers and newborn in our country much safer space and with more survival and quality care, advanced care. So basically my presentation will be it will be organized like what is the current situation now, then what challenges are especially there, especially what we think is problems in our quality of care and referral system. These are the crucial issues. And lastly, the how what is the role of the policymakers. Next. So this is the status. Can you make it full this thing screen? Can it be shown full screen? Otherwise, it is, I don't think it is very readable.
Yes, ma'am, we are doing.
Yeah. This is the present scenario. The MMR, it has come down a lot. The current status is 88 per 100,000 live births. Recently, two reports came, SRS reports. One in May that gave us the report of 2020, 3 years ending in 2021. And now again in June, just 1 week ago, another report came, which is 20 to 22 report on maternal MMR, and it shows again quite a steep drop. First it was 93, and now it is 88. So the health policy says that we must attain 100 by 2020, which never happened. But SDG, we are almost there, less than 70 SDG. So we are quite steadily going there. Neonatal mortality has come down to 19. Infant mortality rate to 2022 is 26. Under 5 is actually 30, because the last report, it has come last 2 weeks back, the latest report, it says 30. And the total fertility is 2.1. So we are almost achieving the targeted goals of SDG. We are on the way. Next. So these are the various interventions which has given rise to such gains in the RMNCH activities. The five, pillars, 6 pillars which are there: family planning, maternal health, child health, immunization, adolescent health, and nutrition. So each, like six big engines pushing the pulling the train forward, and several under each division there are strategies for which are quite interconnected. Then there are several schemes under each strategy, and also there are other programs and schemes. So all this actually has given reason to given rise to this uh, gain, which the achievements which have achieved so far. Next, next, next slide, please. So NFHS 5 says that we have antenatal checkup has increased, institutional delivery has gone quite high, for full immunization coverage is again 76.4%, but again there are regional variations, 95% also in some places. Fertility rate has quite a decline, and contraceptive prevalence rate has increased. Vaccination program has got very much success, and there are 11 nationwide vaccines are there, which is universal, and one is for limited Japanese bean encephalitis is for limited areas. So a lot of success to talk about. Next slide. But the recent recent report, SRS report, the maternal bulletin 2022, there are now again several areas which have we can analyze. There are states where things are not doing so well. They are coming down, the rate is coming down, and the latest report shows that 10 states have MMR more than 88 lakh per lakh live birth, which is the Indian average. India has achieved 88 per lakh live births, and several states, 8 states, they have already achieved SDG target. And most importantly, the very high mortality state till very recently, Rajasthan, as far as the latest report, it has come down to 87. So all the states, they are making their individual efforts, and they are bringing down through various programs and schemes which we have mentioned, and the results are showing in our report. Some of the states, like Kerala, they have reached almost very advanced, developed country status. So we are very hopeful that it will next in 1 or 2 years. This is 2022 report which has come out. So again, now we are in 25. So hopefully things have become much better since then. Next. Coming to neonatal mortality, again, we can see Indian average has come to 19 in 22 report, and 6 states are above that average. Only 6 states, and all the rest, 36 states and union territories are there. So most of them, especially the big states, they are all below Indian average or equal. Bihar is 19. Like that's quite an achievement which have happened over the years. And 8 of the states which are down below, Kerala, Delhi, Tamil Nadu, Jammu Kashmir, Maharashtra, Karnataka, Punjab, they have achieved the SDG target. Next, please. So, what is left now? What should be done? We know all the preconception period, antenatal period, delivery period, postpartum period. All these periods. This central focus is on this every newborn action plan. This is at the time of delivery. That is the most crucial part. And labor, childbirth, this we have to give lot of focus on this period, the peri delivery period, immediate delivery period, labor period, and immediate postpartum period. And if we focus on that birth time, triple return on investment is anticipated, and 3 millions of life can be saved each year in the globally, of course. Next. So these are the contributors to our almost 22,000 annual maternal death, 19 neonatal death per 1,000 live presently. They are mostly preventable. Mostly they're basically due to hemorrhage, infection, and in the neonates, birth asphyxia and immediate post neonatal complications. So lot of them are preventable, especially preterm, small for dead children. So they are the areas where the focus need to be there. And significant proportion of these deaths has been attributed to poor quality of clinical care. Facilities are available, but the quality of care is not so good there. And of course inequitable access for these health facilities in geographically so varying parts of the country, remote places. So a lot of areas are still have access problem and inefficient distribution of health system. So these are the basically policy issues. So they lot of introspection has to come, how to improve quality, how to improve equity in access, as well as equitable distribution of health system. And especially around this period of birth, where 46% of all maternal death and 46% of stillbirth and neonatal deaths occur during that day, during labor. So that is the focus area. Next. So if we look into this area, if we focus into this area, basically it points down, to the referral and transport area, to the health proper level of health facility, because we have delivery rooms, all our delivery points. We have NBCCs, we have first level care, secondary at the in block level we have this thing facility care, and at the district level there are SNCUs, at the medical college level, apex level there are tertiary care centers. So when something happens, and as we all know, pregnancy, however simple or however physiological it can be, there is always a scope of sudden escalation, sudden emergency, unanticipated treatment need. So that time what becomes most crucial is how these mothers and the neonates, they are referred to the proper place. That is the word, the proper place referral has to be there. And for that, if the distance is there, there is need for transport. Transporting sick neonates is not easy. So at risk pregnancy, where we anticipate some kind of problem, it is always safer to transport the mother prior to the delivery in utero transport. Of course, the presently so much is going on extra uterine incubators, extra uterine pregnancies for preterms, but still they have not materialized. So it is always better that the high risk mother always goes to the proper kind of proper level of facility. And it should be, transport should be in a very orderly and skilled manner. The sickest of the newborn require referral to a very sophisticated apex institution or a tertiary care center, but not all need to go there. Some of them can be well managed at a lower level. Most sick babies directly reach medical college or the apex institute, bypassing the lower levels. That is again another challenge, because overcrowding is there in the higher institutes and quality of care suffers. So this centralization again is a very important matter for referral and transport. So we have to see where the baby should be treated, and we must provide the adequate and easy referral and transport. Next. So we must ensure that access is to the nearest and the best facility, appropriate referral and transport, and quality of care. So these are the three things we must focus on. Next. So we must prepare the I will talk more about neonatal transport because I think that is the what has been given to me, the subject. So prepare well before transport, communication, assessment, stabilization, correction of hypothermia. Mothers should accompany, and uh, provider, if possible, it should must accompany. Then there should be skin to skin care as far as practicable, kangaroo mother care, warm containers, incubators if possible, the ventilators and other things. And also ensure all possible care and management during the transport, so that the baby, which is already very sick and fragile and vulnerable, they don't deteriorate before they reach the uh, uh, upper facility, and that is often the cause of the baby succumbs to it. Next next So these are the things which we must assess and stabilize before sending. Temperature, airway, breathing, circulation, fluids. Always mother should be made, accompany if as much as possible, and provider should be there. Next. Parameters are to be carefully monitored and care is to be given during the transport. These are the various parameters, and when we have a sophisticated neonatal transport like this, vehicle like this, so it is easy to possible, is it possible and easy to monitor everything. And most important is communication, so that where they are going, they should already be informed, and parents and receiving doctors should be informed. And even during the passage transport, if there is any deterioration, they should be informed. Next. So this is the summary, that it is a formidable task. It's not so easy, but it can be made simple. SOPs and guidelines are important. Capacity of both the healthcare provider as well as the emergency medic, uh, and others should be very important. The transport vehicle should be functional. All the equipment should be functional, and they should be able to deliver. And family should be made a part of the decision making process always from the beginning. Next. So what is the role of the policymaker? Actually, very shortly I'll describe. Come next. Yeah, so goals are to reduce the mortality, and the previous slide please. Improve access and ensure equity. These are the most important goals for the policymakers. Next. So, what are the enablers? This is a very important slide. If I do not have time to describe in detail that these, unless each of them are in place, it cannot be delivered. The commitment, the support, involvement of private sector, convergence between center and state, academicians and researchers, and civil society organization, all must come together and have all this, in place. IT, accountability commitment, skills to practice, health system strengthening, human resource, and well-defined policies and programs. Next. So these are the various interventions which must be ensured: the coverage, access, and quality, both in antenatal period, postnatal period, delivery infrastructure, and neonatal care. Importantly, SNCU is at the district hospital level. So we have to, empower the NBSU, the block level facilities, and also increase seats at SNCU for the outbound patient, because those who are being transferred, they often face difficulty in admission at the district level SNCU. So outbound patient beds must be increased to cater to the need of those who are being referred from outside. Next. So guideline, SOPs, education, training, practice, that is the mandate of the policymakers. They should be in place. Continuous capacity building activities should happen. Facilities should be prepared for the best. All level facilities, not only at the higher level, but even at lower level facilities must be prepared, to face emergencies. And in that, telemedicine, tele monitoring, all these things now available. Those tools are with us now. And most importantly, the transport vehicle, that one which will carry the baby and mother, so that must be functional, state of art as much as possible. As much advanced system should be there. And call centers must be there, so they arrive in time. Next. Midwifery led care unit, again, another mandate for policymakers, so that low risk pregnancies can be done, helped. And equity and social determinants, that is again, policymakers have to think about, the areas, tribal, rural, urban, poor, how they can be helped, how convergence with other scheme protection schemes are there, and how I see media can be used to create demand, how community can be made aware of them. Next. Death audit, quality audit and death audit, that is again a mandate of the policy, that without that, quality do not improve. Each and every death must be audited. Even near deaths should be audited. Quality improvements through various initiatives must be done. And facility regular audit should be a regular thing. It is not a one of kind. It should be regularly audited, so that it becomes a part of the system. Digital technology has a big role. It has come for electronic health records, for digital training, skill building, telemedicine, tele-mentoring, then data, record keeping, analysis, surveillance, monitoring, evidence-based policy formation. In all, digital technology has come in a big way, and we should find newer and newer ways of leveraging digital technology. Next. Policy support and financing, nothing here occurs without financing. So then again, flexibility should be there, focus on district and state level differentials, partnering with development organized partners, culturally sensitive and effective policies has to be there, and incentivization, motivation of all those states which were in the red. You have seen both in maternal and neonatal, they are more or less common states. So they must be motivated and incentivized. Collaboration is important. A lot of activities are in the private sector, so that cannot be left out. Other stakeholders, community cannot be left out, because that is where the action begins. Research and innovation, of course, promotion of various academic activities, research activities on health, maternal, so that we know problem solving, we know how to solve problems, then sharing best practices and cross learning between the states. So these are the policymakers' role, which I showed in last 4 slides, 5 slides. So NHM and government is doing. PMGI has come in a big way, where very sick mothers and newborns, survival can be influence impacted through PMJY. More and more use of these schemes. Thank you very much. I think I have done it. Next. Next. Yeah, thanks. Sorry if I have taken more time, but this is an area which needs to be, you know, it needs a lot of discussion. Thank you.
Thank you so much, ma'am. Mugda, over to you. We'll take that.
Thank you, Ria. Dr. Sumita, I I had a bunch of questions prepared for you, but it seems like your presentation was so comprehensive that you've already answered everything I was supposed to ask. So, maybe a unique question over to you. We learned a lot about the policymakers' role and, digital interventions and something as simple as a better ambulance and building capacity amongst healthcare professionals. But what about the patient? You did mention that family members should be involved in this entire decision
I
making
did
process.
mention, I might
Yeah.
have not mentioned elaborately because community is the where the action begins. Their education, the demand for services. If the services are there in the facility and no one comes, then it is of no use. It happens in many places. It happens. So underutilized services remain under. So women have to be. If you read the thing, I think you will get all the points. Maybe I did not mention because I hurried through them. Education of women, that is very important. Their demand that I must be healthy and my child must be healthy, that actually drives everything. So community awareness, community engagement, and their demand for service from the mothers, from families, from couples, they are off, because things which we supply, it might reach, might not reach, but if they demand, then the of course the supply and demand, if they match, then that is the best thing that can happen.
We do talk a lot about building capacity of patients, and that is something, patient organizations, civil society, as well as the government has been working very hard to do. Can you tell us any mechanism with which patients are able to give feedback that helps policymakers implement ground level, realities into the decisions that are made at a central level?
Uh, Various mechanisms have been set up. There is one, the ashas, they regularly hold mothers meetings, like would be mothers or already mothers. They gather together, they discuss, and they convey their things, of course, to Asha, so that she can solve things at her level. In facility level, there are, Mera Aspatal, where people can really put in their feedback and all, and lot of self-help groups and NGOs, they are working and they are partnering with government in ICs, in kind of awareness generation. uh, so they are actually working. Otherwise, how this within 1 year, the latest 21 and 22 MMR drop is from 93 to 88, and that also during some hard COVID period. So that is very encouraging that people are being aware. Otherwise, just by giving, the mother comes at a very late stage with lot of complications. Caregivers or facilities can do very little. Severe anemia, this kind of things cannot be helped at the last moment, because pregnancy is a long period, 9 months. The baby grows 9 months, mother bears it 9 months. So if the woman does not take care of herself, the family does not take care of herself, or the community doesn't, so it's not possible, that only one point intervention will help. So a lot of activities are there. Of course, there is always need, because we are yet to reach our 70, and when Kerala has achieved 18, I think 18. So it is possible with that kind of awareness and that kind of activity. What Kerala has done, basically private, government, they have developed a very interesting health system. So where private providers are also sort of so many things in maternal death audits and many many other things, they are part of the government of system. So that kind of system has to develop, where women demands, and she must not stop at not getting it.
Thank you so much, ma'am. That was a very good response. And I think it's a wonderful segue to our next speaker, Dr. Rajesh, because based on some of the success enablers, I think Dr. Rajesh can shed some of the global best practices for us, as well as taking inspiration from, some success stories within India as well. Over to you, Dr. Rajesh.
Uh, Thank you. Thank you so much. And I must also acknowledge uh, and appreciate the request to participate, because that brings me into a panel with the dear friends like Dr. Samita Ghosh. I have had pleasure of working with her in her ministerial capacity, and with Dr. Neelam Clare when she was president of Neonatal Forum. So it is good to be in a panel where I have very powerful ladies who have led the work in India. So my presentation would largely illustrate how India has led the program, and I will build upon what Dr. Sumita Ghosh has already, set the stage with. So a lot of hard work has been put into this achievement. So we must, acknowledge in the first step itself that it is very commendable that government has progressed, so much. Look at this trajectory. She was mentioning newborn mortality has reduced over the years, and we did also, start the progress from MDG phase. This is the MDG phase. In 1990 we were here, and look at the fall to when in 2022 we are, almost at 19, as we mentioned, that neonatal mortality has come down so much. In the process, the reduction is huge, 70% reduction, uh, uh, since from the baseline. And we are saving additional lives because of that. Uh, but India is a big country, big population. We have 25 crores or 250 million, or maybe a little less now because total fertility has gone down uh, uh, every year. So the annual cohort is so much, and with mortality reduction also, we have still 400,000 neonatal deaths in a year. And Dr. Sumita mentioned, and I will build upon the case that many of these are preventable. So we acknowledged, Kerala can show results the best of the world. The neonatal mortality single digit is our goal, national goal, and 3 states have already reached. And Dr. Sumita mentioned all of this, but it is good time to again acknowledge that a large part of country has already reached SDGs, and 3 states have reached the national goal of single digit by 2025. Hugely successful story for other countries also to look at. The common causes of deaths have changed over time. This is newborn mortality now. We the four major causes are prematurity, of course, remains at the top. We have low birth weight and prematurity and complications. 41% mortality actually in newborns in India comes from complications of prematurity. The second component is birth asphyxia and birth trauma, which happens at the time of birth. But surprisingly, now birth defects or congenital anomalies are gradually taking number 3 or number 4 position, while infections have gone down. So this is, a story of epidemiological change, where infections have gone down, and other causes have also reduced marginally. Therefore, birth defects now are proportionate mortality as a cause of proportionate mortality has progressed up and up. So the story is that now we have to take care of birth defects also. And Dr. Sumita did mention that the critical points to save lives are around the time of birth, and taking care of small and sick newborns. And India has done particularly well in both. Therefore, we have seen mortality reduction, and we can still achieve more because 40% mortality reduction still is possible by improving quality and coverage around the care around the time of birth, both for women, newborns, and also prevention of stillbirths. And of course, huge success story through special newborn care units, which India has led the world, and many countries have followed. So two principles we must follow, that all the services and interventions which we know can save newborns have to be delivered across life course. Because 48% of newborn survival actually depends on interventions delivered to the mother. So if you keep the mother healthy, and if you, even before pregnancy, during pregnancy, of course, we have to take care and a lot of antenatal care is given. But before pregnancy, also, it is important that the health, nutrition, and well being of young women and girls is ensured. So, if you don't act here, the 48% impact would be lost. So, therefore, we have to work across the life course continuum. And second, the principle of this life course continuum is that mother baby couple or diet has to be preserved. We cannot separate mother from the baby, and two of them together have to pass through the health system so that we have advantage for mother's survival and baby's survival. The second important healthcare continuum is that some services have to be delivered at home and in the community settings. Some of the interventions would be possible to deliver at primary level of the healthcare, and some babies and mothers with complications and who get additional, sickness, they will need to get referred to higher level of care. So we need services delivered at all three levels of care: home, community, first level, and referral level. So we know what is to be done. 70% of newborn mortality can be prevented through what we know. And again, the principle is across the life course and across the healthcare, continuum, healthcare levels. All these interventions have to be given, which are summarized here. Dr. Sumita has spent time on this. So we say before pregnancy, care during pregnancy, during the birth, at the time of birth, and then post neonatal period and newborn with complications. So clearly, care before pregnancy largely happens in home. Care during pregnancy, antenatal care, in outdoor settings and in homes. While if there is a complication, patient must visit OPD or even admitted if there is hypertension or severe anemia, as Dr. Sumita was pointing out. So care happens at home and in hospitals. We prefer that care at birth must be delivered in the hospitals. So therefore, we are, in favor of institutional deliveries, and therefore there is no scope or recommendation for home deliveries at the moment. Similarly, if there are complications in women and newborn, they have to be treated in hospitals. Postnatal care usually happens in home, but when the children become or newborns become sick, they have to come to hospital. But hospital care is followed up at homes, which is also critical. So home hospital connections have to be very clear and strong. And Dr. Sumita did mention about referral pathways and effective transport mechanisms to make it happen. But again, she made a point that good quality and safe care has to be there at all levels of care, at homes, at the first level hospitals or health facilities, and at tertiary level facilities. So health system, has to deliver a quality of care, which Dr. Sumita mentioned. So my take on this is, we know that health system has to deliver. But it is equally important that the community, the patient groups, the clients, the families, they must be empowered and they should be aware that it is their right to seek services from a health system, because there is policy commitment and there is government's, acknowledgement that health is a right of the population. So it is clearly, described that health is part of care, the right to life. So right to health is an essential fundamental right in our constitution. So we must actually empower the community. Therefore, we did have discussion in the last part of the session that community engagement is clearly important. The community should have voice, but community should also have teeth to actually hold the health system accountable. And it is not that it has been done without much effort. Government of India has done huge things. This is a list of the interventions, the schemes or the programs which people like Dr. Smita Ghosh have steered. I have pleasure of working since 2000 with various national program managers, and the last one was Dr. Smita Ghosh. They have done so much. Uh, this is a matter of detail. Without this, we would not have progressed in mortality reduction. And especially for home community based, there is a special program where Women and Child Ministry, Ministry of Women and Child Development, through their ICDS program, implements home based care and nurturing care, for example, which is important for early childhood development, uh, collectively together for the babies. So, because government has done so much, therefore the coverage of interventions has increased. The remarkable example Dr. Samita mentioned was that from 40% in 2005, when the National Health Mission was launched, with Janni Suraksha Yojana as a flag bearer, as a flagship program, from 40 to 90%. Look at the steep rise in institutional deliveries. This is remarkable and has been acknowledged worldwide that India has done wonderfully well. Except for breastfeeding, which remains a lingering issue, we have seen progress in coverage increasing, and therefore mortality has reduced. But we know that coverage is uneven. There are wide inequities. Many people are left behind. Therefore, there are, empowered action group states. There are aspirational districts and blocks where government has provided additional, resources and additional strategies look to catch up with inequalities so that there is equity finally in the health care. Uh, and look at here, institutional delivery. This is blue line is the poorest families, and red line is the richest families. There is a significant gap in services. Same with antenatal care. So there are other determinants. Poverty is one. If the mother is not educated, if they are living in remote and hard to reach areas, if they are socially marginalized, there are migratory populations. In urban poor, for example, in humanitarian situations, there are inequities, and government is aware of that. And therefore, we have seen schemes and innovations. And she mentioned there are a lot of digital mechanisms now available. And aspirational district program, Dr. Sumita is now working in Niti Aayog, and Niti Aayog is steering aspirational district program, where a lot of additional elements have been infused to take care of maternal, newborn, and child health. She mentioned about this assurance scheme through Prime Minister's, this Ayushman this Ayushman program for reimbursing 500,000 rupees for a family in a year, which includes newborn and maternal health packages. So we have now currently Ayushman Arogya Mandirs, which will further try to, bring in services for marginalized people. For quality of care, again, government has done a lot. National quality assurance schemes are there. There is NQA certification, which is happening. Lakshya certification, Muskan certification for maternal and child health, hospitals. Kayakalp, she mentioned Mera Aspatal, which is a feedback mechanism. Then a lot of quality improvement issues, death review systems. There is a web-based death review system in India where, periphery, right from periphery, the deaths can be reviewed and analyzed, and web system will capture when the review reports are mentioned. There is line listing of deaths, and there is review of cases, and we know how deaths can be prevented. So a lot of good work is going on, and there are patient safety programs as well. So it's not just survival. Now, since babies are surviving, we must ensure there is quality of life. So it's about beyond survival also. We know preterm, complications are there. When they survive, they should not have retinopathy of prematurity. They should not have lung dysplasias. Their neurodevelopment should not suffer. So therefore, we must take care that newborns, after they have survived, they are given best of opportunities to prevent any damage which can, affect their lives. So therefore, holistic development and nurturing care for every newborn, actually starting before birth, from conception to first 3 years, there is a big program which government has, introduced in the IMNCI, as well as in home-based care and home-based child program, which will be implemented at scale very soon. And through RBSK, which I mentioned in the list of programs, development monitoring is possible, and it is easy. It will be possible to detect neurodevelopmental delays and refer them appropriately to the district centers where necessary support would be available to families. And all of this continues across life course. Newborn development leads to child health and development programs, and then the children are then looked after through adolescent health programs. So there is a big, push. Participation of parents and families is extremely, important, and it was mentioned in the previous presentation as well. The partnership, respect, and dignity to the families, to the parents of the newborn who are there in the healthcare system. In the family should be informed and involved in decision making about the care they are going to receive. And this individualized care and focus on family functioning is all very important. So India has actually now expanding a family participatory care program where families are actually allowed role in taking care of newborns within the special newborn care units and intensive care units in the hospitals. So we must include family members in consultations and treatment planning, providing educational materials to them, creating welcoming environment to families, and they should be equal partner in treatment, which the system wants to offer. There are clear benefits that there is improved communication between the healthcare system and the providers and the families. There is improved patient and family satisfaction, increased adherence to treatment plans, so compliance is improved. There is reduced stress and anxiety for parents and families, and there is also potential for clearly for health outcomes. So therefore, family participatory care actually is set up within the people-centered care. That's a big principle which must be followed, that the healthcare system is delivering services which is people-centered, which is human-centered, and within which there is a family participatory system which allows families to participate in newborn, child, and adolescent treatment as the system delivers the services. So enhancing the role of clients in healthcare is clearly important and catching up. And therefore, Dakshayani probably uses patient groups, and those initiatives must come up more and more. The asymmetry between the healthcare providers and the receivers of care must be reduced. The empowerment of patients is clearly important, and therefore patient groups is a good idea, that patient groups actually sit in the Ministry of Health, guide formation of policies, tell their preferences, how the services should be delivered, so that the health system delivers services which are in tune with the expectations and preferences of the clients who will use the services. So safe care for every newborn and every child is the theme of patient safety this year globally. And it is important that the Shiny has chosen this theme the idea is to reaffirm every child's right to safe and quality care. And it builds upon many patient safety programs which have gone on in the past, mentioned here. But objectives of this year's Patient Safety Day is to raise global awareness on safety risks in pediatric and newborn care, mobilize governments and stakeholders, and empower parents, caregivers, and children in patient safety. So all the health system actions which I described and Dr. Sumita described, there is an underlying push on ensuring good quality and safe care. So therefore, the NQA standards actually include many of these parameters, and therefore we have to deliver on those standards of care, which the national standards are there. So before I wind up, the request was to also share how much other countries in the region may be doing, or globally, if there are other countries where something else has been done. I'm so happy to first acknowledge that India's SNCU model, the Special Newborn Care Unit, which started 20 years back, even earlier, from the first unit in West Bengal in Purulia, and then first prototype of SNCU in Madhya Pradesh, and then UNICEF supporting few units, and then Government of India quickly taking over, and now we have more than 1,000 special newborn care units where lives are being saved. So this model was exported through SARC Development Fund, which Government of India provided to 6 neighboring countries. And this district level modeling was possible to demonstrate through Indian experts in Afghanistan, in Nepal, in Pakistan, in Maldives, in Bangladesh, and in Sri Lanka. Even Sri Lanka adopted this district model of level 2 care because that piece was missing in Sri Lanka, although they have delivered good results already. So India has exported some of the good practices, and this actually found its way through development partners to Africa. When I talk to some African countries, they have actually adopted similar approach which India had initiated. Similarly, bringing in ASHA as a community health worker has also been adopted in many countries. Ethiopia, for example, from where our current Director General of WHO comes from, they actually replicated something like ASHA in their system, and they have also evolved, that community health volunteer, mechanism. And Dr. Sumita also acknowledged that ASHA does a lot of social mobilization, uh, gathers community groups, mothers groups, and helps them to avail services, but also practice good, healthcare behaviors, and then brings their voice back to system to say, uh, this is how we improve. So in my region, in our Southeast Asia region, when I worked for the regional office, we found community-based care actually is available in at least 8 of 11 countries in some form or the other. And this mechanism has been well understood that the home-based and first level care and tertiary level care have to be connected. And there has to be continuum of care. Uh, so if I look at the policies and analyze policies of the 11 countries in this region, mostly I find they have actually adopted the practices which I have enunciated in my presentation, building upon what Dr. Sumita had set the stage with, that we have policy environment and practices which are also seen in other countries, and India has been leader in some of them, which I gave you an example. So I stop here and thank you for this opportunity. Um, my favorite is, we must keep babies and mothers together always. Thank you.
Thank you so much, Dr. Rajesh. That was very insightful. Um, so we talked quite extensively about the progress that India has made in terms of coming up with an astounding healthcare system, that is not only able to show progress within a very large population, especially with the, complex public-private healthcare system, but is also being adopted by so many countries. So we meant, like you and Dr. Sumita as well mentioned, that quality of care is one very big important factor that has helped the current healthcare system to be so effective in what it aimed to do. So for the benefit of the audience, can you please elaborate on hospital-based safety audit mechanisms? What is it and how has it helped the system?
Uh, we acknowledge this is a little bit new in the area of healthcare delivery system. we must recall when we were doing Millennium Development Goal, for example, from 2005 to 15, the emphasis was largely on scaling up interventions. So all the countries actually followed the guidance and everyone started scaling up without minding the quality so much. Quality became a little bit of, afterthought, but scaling up did happen. So I think we achieved the purpose that during those times scaling up happened. And 2018, when there were two big publications which were there, Lancet, series Lancet, and then another, Institute of Medicine in US, when they analyzed, they found 60% of mortality in maternal newborn and in other sections of healthcare actually is happening because of poor quality compared to non-access to services. So Dr. Sumita made a point that people have started coming to health services. But deaths are now happening because we are not able to deliver the evidence-based interventions fully. So when I say quality of care, actually patient safety is an embedded component in quality of care. While it needs little bit of more policy, manifestation, uh, there is a policy on patient safety in Government of India's from the health system. But the culture, the work culture actually has to continuously evolve now. Accreditation is going on. We are doing certification of MCH units largely. Look at the MCH. It has been a pathfinder for the whole healthcare system. Quality is not just important for maternal newborn child health. It is also important for cardiology, for surgery, for other areas of care. But MCH has led the way because there were conscious people, there were good people in the sector which were doing this. So certification has happened. Now certification cannot stop at that level of achieving the standards. We must continuously improve the quality. So therefore, in Lakshya, there are improvement cycles mentioned. And then we prepared a point of care quality improvement tool, which helps healthcare teams to constantly keep on improving and do not wait for the next cycle of certification, right? So within which there is patient safety. Now, COVID taught us that without hand washing, there is no safety, right? All of that hazmat suits and personal protective equipment, despite everything, hand washing became the top. So we had alcohol rubs within the wards. Never seen. We invested under pressure. We only had wash basins and some small bottles of alcohol. Now between two beds, there is a hand hygiene mechanism. So that is a huge patient safety gain because we learned. Then to keep patient safety, say there are fire hazard norms, there are regulations that each hospital has to prevent fire incidents. Unfortunately, still keep on happening. Whether we are making mistakes in medicines, are we using the medicine safely? There is a policy on that. Look-alike medicines, sound-alike medicines, mistakes in prescription, mistakes in dispensation. But the work culture actually has to learn to report these events, which is difficult. It's a cultural issue that many patients, many people, healthcare, providers actually have a fear that if we report a incident, we will be punished, right? And then there is an overall, fear that if quality of care is so fully understood, then patients will go to the court of law and say, poor quality was given to me. So we have to come out of that. We have to, do away with the blame culture, shame culture. We have to promote reporting of patient safety events. And then there are mechanisms to prevent that next time should not happen. We have not arrived there. We have started the journey. NQS is a very strong system. It must be, supplemented with quality improvement mechanisms. It must also separately also emphasize patient safety. There should be no falls in the hospital. Patient should not receive any electric shocks. Newborns should not, be overheated. So all of those safety issues are clearly important. Why should we give unnecessary treatments? Why should we give, antibiotics when not required? Why should we give oxygen when not required? Why should we give IV fluids when not required in neonatology? So all of those are, safety and quality issues. So we are going there, but it will take a little bit of time and efforts, and we are happy that all of us are following that journey.
Dr. Rajesh. I think at the essence of all the, the great points that you mentioned is that we have to be very aware of the preventive measures that we can take on a personal level to be educated, to make sound decisions, and to, like you said, healthcare starts from home in the sense that even before a child is born, the preventive measures can be started with good vaccination and, not consuming medicines that you're not supposed to consume and taking precautions, etc. So moving on to the next speaker. Dr. Neelam will be talking about preventing birth asphyxia and neonatal infections. Over to you, Dr. Neelam. Thank you so much, Dr. Rajesh.
Thank you so much, Dakshani, for giving me an opportunity to speak on a webinar on a subject which is very relevant and very beautiful and very close to our hearts, patient safety and talking about safe birth and neonatal care, strengthening the healthcare system. And I'm glad that stage has been already set by people like Dr. Sumita Ghosh and Dr. Rajesh Mehta. Both are friends. I have worked very closely with Dr. Rajesh Mehta during my close association with National Neonatology Forum. I'm glad that, they have sort of given a scenario or a stage, what has happened and what is happening at the national level. As you understand that I am basically a neonatologist, a neonatologist who's a clinician, who's working as an intensivist in a tertiary care system. But I'm well aware of what is happening because of people like Dr. Ghosh and Dr. Rajesh Mehta and my very close association with NNF. And also right now working with an NGO called Basic Health Services, which work at the last mile communities in Rajasthan. And they have a kind of a hub and spoke model. So I'll spend a little time in just maybe repeating few of the things which have been already said to just set the stage, but very quickly. And then how can we prevent sepsis and perinatal asphyxia? I prefer to call it perinatal asphyxia than birth asphyxia, being a neonatologist and being very close to perinatal health. So can you share the slide, Ria? Okay, can you make it right?
Is it visible now?
Yeah, but could you make it the full slide?
Neelam, on my screen, it is full.
Okay, right.
Yeah, you can go ahead.
Fine. Then I'll go on. Maybe then there's something wrong with my screen. I think I'll change the view in a minute. Standard, right? Yeah, thank you so much. Thank you for helping. So as it has been already mentioned, and I would be emphasizing on prevention of birth asphyxia and neonatal infections. Would you be moving the slides or should I move the slide? Okay, I can do it. So as it has been already said that, it is important to prevent neonatal mortality because deaths among children under 5 has been more responsive. And the decline rates in case of neonatal mortality has been rather slow And that is why we are more concerned. And as neonatal deaths constitute a major portion of under 5 deaths, and India being a large country with large number of births, we are concerned about reducing the neonatal mortality. So if we look at, could we go next slide? Thank you. Okay. So if you look at the determinants of neonatal mortality, which have been already very beautifully illustrated and also kind of brought to the notice of everybody, that, when we are looking at newborn mortality, we are looking at different areas. We are looking at the community factors, community level factors, which could be the distance of the mother from the health facility, or the approach by the healthcare worker, or how strong are the healthcare programs over there, the education of the mother, and the economic status of the mother. And if you look at the socioeconomic factors, again, the education, the religion, the caste, employment of the mother, and the environment of the house, everything plays a role. And if you look at the proximate determinant, again, the maternal factor like mother's age, neonatal factors, sex of the child, male versus female, pre-delivery related factors, time of the first antenatal care, frequency of the antenatal cares, and so on and so forth. So all these determinants, they affect the neonatal mortality. So if we look at the neonatal mortality, as already said, that it has come down drastically, but it is heterogeneous. If we look at the burden in urban versus rural, in certain states versus states like Kerala, rich versus poor, the mortality is very, very heterogeneous. So is there something we can do? But before that, if we look at the SDG goals, we see that, we need to decrease the NMR by 12 per thousand by the year 2030. So probably we need to do something more. And this slide has been already emphasized by Dr. Rajesh and also by Arpita. If we look at the certain targets for the SDG, you see that, some of the targets, like the proportion of birth attended by the skilled health personnel, we have achieved better. But if you look at the antenatal visits, we are still lagging behind. Similarly, if you look at the proportion of infants who were breastfed within the first hour of life, we are below 50%. And this is something which is a low-hanging fruit. And this will not only improve the neonatal survival, but also will reduce the risk of neonatal infections. Similarly, if you look at percentage of infants who are being breastfed at 6 months, we are still hovering around 60%. So I think probably more needs to be done if we want to reach the SDG goal. This is something which was published in Journal of Perinatal Medicine in year 2015, looking at the causes of neonatal infections. And the number of newborn dying in the first month of life have come down from 2015 to 2023. Similarly, the number of babies, a number of stillbirths have come down. But probably, we need to do more. And I think around 2000, the first decade after the millennium was the best decade for the newborn health. As Dr. Rajesh Mehta said, we established a model of a sick preterm neonate, and we established the SCNUs. And these SCNUs at the district hospital became the referral hubs for the patients from the community. So what we called as a perinatal regionalization was not only on the paper. In the perinatal regionalization means that from PHC to FIU to the district hospital to the medical college, but the district hospitals were not having the kind of neonatal care where we could save more preterm babies. And as you can see that majority of the babies, they die of prematurity. So I think one of the good things which happened was the establishment of SCNU and establishing a model for preterm sick neonates with respiratory distress. But as Dr. Arpita very rightly pointed out, that some of the lacunae are referring a baby from one referral unit to another unit or to the higher unit. So the transport or the linkages have to be very, very strong if we want to really say that the perinatal regionalization is not just on paper, but is actually there. So my task today is to basically talk about the strategies for reducing perinatal asphyxia. A healthy, lustily crying newborn is not only a joy for a mother, but also for the family. So when we are talking about perinatal asphyxia, we should not forget about hidden deaths, which are underreported, and they are the stillbirths. So if we look at the burden of stillbirths, the stillbirth rate is still 13 to 16 per 1,000 births. So the annual stillbirths are around 400,000, which is a huge burden. And it is probably a hidden burden, which we are not seeing. India's global share of stillbirths is around 25%. The SDG goals target to reduce the stillbirth rate to under 12 per 1,000 by 2030. And we know that there are high burden states like Bihar, Uttar Pradesh, Madhya Pradesh, Assam, and also there are certain better performing states like Kerala. And we need to learn from the better performing states that what they are doing differently, which the high burden states are not doing. We know that the major causes, the first 4 causes are preventable actually, like anemias, malnutrition, malaria, syphilis, torch, poor antenatal care and delayed referral and delivery complications. But as Dr. Mehta pointed out, a large chunk now is also because of congenital anomalies and growth restriction. So that is why we have to focus on this also. If we look at the determinants of perinatal asphyxia, then probably, again, as we know that maternal newborn diet is so deeply embedded in the community that there are socioeconomic determinants like low maternal education, poverty, cultural beliefs, and maternal health factors like lack of antenatal care, teenage pregnancies, advanced maternal age, high parity, poor maternal nutrition, and delivery related factors like home deliveries without skilled attendant. Though the institutional deliveries have increased, but we have to focus whether these babies in the institutions are being discharged early, are they going back home in a state that they are salvaged and somebody is looking after them in their post-neonatal age. Delayed referral and prolonged obstructed labor still remains a problem. We need to improve the emergency obstetric services. Health system factors like inadequate infrastructure, shortage of skilled birth attendants, distance to the health facility, and poor emergency transport system remain the factors leading to high burden of perinatal asphyxia. Environmental determinants, which are like those mothers who are living in the areas which are hard to reach, unhygienic delivery conditions, and certain neonatal factors like preterm births, low birth weight, and congenital anomalies. Community level interventions like the education, health education, strengthening the community, promotion of the institutional deliveries, and also the most important thing, improving the transport system. The definition of birth asphyxia, which is given by the WHO, is a little loose definition, which just says failure to initiate and sustain breathing at birth. But I think the time has come that even WHO should improve on on this definition, because we may be over calculating asphyxia. I tried to divide the levels of prevention into 3 categories: primary, secondary, and tertiary. Primary is preventing the onset, secondary is early detection and prompt management, and tertiary is minimizing the complications. The primary prevention basically targets the entire population, avoids occurrence of asphyxia, and can be improved by the basic focusing on basic care like maternal and fetal health before and during labor, ANC, management of maternal condition, skilled birth attendance, and clean delivery. Secondary prevention, which could be applicable in like SCNUs, is targeting high-risk pregnancies, early recognition and rapid response, providing and monitoring fetal distress, intrapartum monitoring like CTGs and partographs, timely cesareans or assisted delivery, and readiness for neonatal resuscitation, and making sure that the equipment and the infrastructure is available. And tertiary prevention, which could be in a large hospital or in a medical college, would be targeting the newborns with asphyxia so as to reduce the severity and complication, and providing NICU care, therapeutic hypothermia, and providing not only the NRP protocols, but also training and educating the lower or the secondary care facilities. Also providing post-asphyxia supportive care, early detection of complications, and taking care of long-term neurodevelopment follow-up. So we have to not just leave at the care at birth, but also take care that we are looking at their long-term care also. There are huge challenges. It looks easy on the paper, but I know that integration is very important. There is a lot of role played by the healthcare systems, training, and community. I think the district hospitals or the SCNUs should have mentors who are periodically training the staff, making sure that they are trained in various skills. Otherwise, like, they would forget the skills and things will again go to the zero station. Other barriers are the barriers are lack of trained staff and infrastructure gaps. Again, as I said, that it's very important to have the retraining and making sure that the staff is trained. The solution probably lies in capacity building, the medical colleges coming forward, the professional organizations coming forward, community education, and of course, policy support from people like Dr. Ghosh and others, so that we can support the system. As it has been already emphasized that there are a lot of initiatives by the government for prevention of stillbirths and asphyxia, like INAP, Lakshya, Janni Suraksha Yojana, Poshan Abhiyan, Anemia Mukt Bharat, so which are trying to help combat the maternal nutrition, improving the labor room quality, and improving the health of newborn. Being said that, let's move on to what could be the strategies for reducing neonatal sepsis. And as Benjamin Franklin said, an ounce of prevention is worth a pound of cure. Just to give you a preview, Dr. Mehta was talking about reduction in the neonatal sepsis. But, we are facing now a new problem, and the new problem is antibiotic resistance. And this is a very recent study, which is from the Delhi public hospitals, large hospitals, medical colleges, where a huge number of neonates, like 13,530 neonates, were studied, and of them, about 88,000 were enrolled. And the incidence of sepsis were 14.3%. Culture positive were almost half of it. And nearly 2/3 of the infections, they occurred in the first 72 hours of life. And what is very frightening is that 2/3 of these isolates were gram-negative, like Acinetobacter, Klebsiella, and E. coli. And there is a very, very high multi-drug resistance observed to almost all the gram-negatives. So this is something which is a little scary. We have already enumerated that the risk factors for neonatal sepsis could be maternal, like prolonged rupture of membrane, urinary tract infections, chorioamnionitis, premature labor, and socioeconomic status. So taking care of the health of adolescent, making sure that reproductive infections are treated, and hygiene, especially the menstrual hygiene, is taken care of. Neonatal risk factors like low birth weight, low EPCAR score, prematurity, and hospital risk factors, which are like infection control practices and taking care of antibiotic resistance, are important to study. If you look at the infection control steps, the most important thing is to prevent the entry of microbes into the baby ICU or into the labor room, prevent the proliferation of microbes in that area, prevent the infection spread, prevent the entry of microbes into the infant. And one of the very important strategy, which we should not forget, is breast milk, breastfeeding. For premature babies, breast milk, availability of breast milk, and breastfeeding are very important. KMC, or kangaroo mother care, is one of the strategy which can improve the breastfeeding, improves the health of the newborn, and leads to early discharge from the ICU. So that is very important and is being advocated largely. Infection control protocols, we talked about QIs and quality initiatives. I'll be very briefly talking about them. Before that, I think the only strategy to prevent the entry of microbes to the neonates is to have a clean environment, clean hands, clean perineum, clean delivery surfaces, clean cord clamping, clean cord cutting, and clean cord care. And it looks very easy, but unless and until you do the audit, whether your hand hygiene is being practiced or not, it will not be done. It has been seen that a nurse would be touching a baby during her shift of 8 hours, something like 200 times. So if you want to ensure the hand hygiene, probably auditing and vigilance is very important. This has to be emphasized that hand hygiene has to be practiced at all the 5 moments when a microbe can enter a patient. And this could be before touching the baby, after touching the body fluids like changing the nappy, or handling the blood or any other body fluids, after touching the patient's surrounding or the baby's surroundings, after touching the patient, and before clean or doing an aseptic procedure, one has to make sure that hand hygiene is being practiced. Well, hand wash is something which should be done very diligently and not just as a kind of a compulsion. The duration of the entire procedure should take 40 to 60 seconds by the watch. And all the steps should be practiced. And it is important that if you put all the steps in your labor room or in the baby care unit, so that, anybody who's doing the hand washing is vigilant. The WHO guidelines recommend you can use alcohol-based hand rub for 20 to 30 seconds instead of the soap. But if your hands are obviously soiled, then you should wash your hands. And also, you should make sure that your visitation policies and bringing jewelry or fingernails should be prohibited. One should avoid overcrowding and also avoid airborne infections. If anybody has cold, cough, should wear mask or should refrain from coming to the ICU or the labor room. And you should have hand washing stations within 20 feet of of the baby's bed. So if you want to prevent proliferation of microbes in the NICU, good housekeeping, avoiding wet areas, dry and clean NICU are unlikely to harbor microbes and are very, very essential. You need to have daily routines and weekly routines. So these routines should be religiously followed up. So like daily routines are cleaning of the baby beds, like incubators, syringe pumps, infusion pumps, the humidifiers, laryngoscopes, and they should be cleaned as per the protocol, and the protocol should be always available in the NICU or the labor room. Weekly routine in the NICUs, like, certain things like ventilator circuits, CPAP circuits, or other procedure sets are cleaned weekly. So those protocols should be available, and everybody should know that where they are available, they should be easily accessible by the staff. As I already said that, if you want to improve the care and want to reduce the spread of infection, then it is high time that we provide the proper nurse-patient ratio. We use either disposable or make sure that, anything which comes in contact with the baby is sterilized. They should have separate gloves, separate suction catheters, separate syringes, separate resuscitation kits. And if you are using fluids or parenteral nutrition, then you should have laminar flow hoods in your NICU or in the area where you're taking care of the babies. So the most important thing for infection control is to have a committee or a group of people who run a program of surveillance for the prevention and education, so that you can study the epidemiology and do the surveillance, look at your data, look at the incidence of your hospital-acquired infection, your line-associated infection, your ventilator-associated infection, and you can look at the trends. Ensure that appropriate staff training in infection control and safety is done. Provide inputs into investigations of epidemics, and periodic audits are necessary. Also, to prevent the entry of microbes to the infant, make sure that the cord care and the skin care is done religiously. This is just to show that how quality improvement can reduce the risk of infection. This was one of the quality initiatives which we ran with Institute of Health Improvements, Massachusetts, and with ISB, Indian School of Business. And we looked at 2-year data, and we were auditing the processes like hand hygiene or the bundles practiced during the care of the line, the IV line or the central line. And we looked at the reduction of infection rates. So our aim was to bring down the hospital-acquired infections by 40%. And as you can see in this chart, you can see that, we could bring down the central line associated infections from the month of June to the month of May, June. We could bring down from something like 18 to even above 18 to something like around 2 to 4. And this initiative was done with the PGI Chandigarh, with the Chandigarh Medical College, with the Kochi Amrita Institute, with Fernandez Hospital, and with NICE Hospital in Hyderabad. So there were 6 NICUs, which were like tertiary care NICUs, which came together to study the processes, audit them, run PDSA cycles. PDSA cycles are plan, do, study, act. So like, you plan a initiative like, that, doing this is going to reduce my rates of infection. So I say that, doing bundles, that is, the care of the line, intravenous line, that it is introduced under all the sterile precautions and it is maintained with all the sterile precautions. So there are like, 5 or 6 objects. You make sure that, they are ticked and they are being practiced. And as you do your processes, you also study the risk of infection, and you see that your central line infection has come down. So that means these PDSA cycles or these plan, do, study, act cycles brought down our risk of infection. So this is just one example. We did it for ventilator-associated infection. We were also studying the hand hygiene, how it improved from 60% to 80% to 100%. So similarly, you can do for other things also. Lastly, you have to also look at antibiotic stewardship, and it should not be just in paper. Every patient, you should question why you started antibiotic, how much duration they should be there. Once your culture reports come, and if supposing antibiotic of lower generation is sensitive, then de-escalate the antibiotics. Don't use too much of empirical antibiotics. Use it for short time. And once you're sure that infection is not there, stop them. Appropriate use, a dose, routine dilution, and 1 or 2 drugs, and don't use multiple. Many a times babies come from health facilities and they are on 4 antibiotics, 2 antifungals. So don't add, subtract, and do cultures. The key messages are that ensure sterile birth practices, encourage breastfeeding, enhance surveillance system, optimize antibiotic usage, emphasize infection control in hospital, and raise awareness among caregivers. As Dr. Mehta said, I am also a great advocate of mother-infant nexus to be kept together if we want to provide holistic care to mothers and newborn. Because newborns are embedded into the community, they are dependent on their environment, or their health is dependent on their environment. They are also dependent on the caregiving practices and also on the social identity. The social identity of the mother decides the social identity of the newborn also. So, I mean, we have to provide a holistic care to mother and newborn, starting from the community to the first or the final health facility, and the linkages and the transport, I think, are very, very important so that we can talk about perinatal regionalization in practice and not in paper. Thank you so much for giving me an opportunity.
Dr. Neelam. Maybe to summarize everything, health literacy, I suppose, that at the crux of all of it, right? Safe use of antibiotics, washing your hands regularly, healthcare audits, understanding what do you have in terms of, infection and how to prevent it, how to de-escalate the amount of treatment styles that you're consuming. So AMR has been something that Dakshani has been working a lot on for several years now. So Dr. Neelam, in your opinion, what role do digital tools such as training programs play when it comes to improving access and health literacy so that people are more informed?
I think they play a huge role because now on the digital platform, we have simulators also. And at least in neonatology, and during the COVID period, we have the experience of running teaching programs, workshops digitally. And, now, in fact, there are point of care teaching programs also, which are going digitally. So subjects like, prevention of perinatal asphyxia and dissemination of neonatal resuscitation can be done digitally. But, since simulators need hands-on practice, so I think some bit of hands-on practice is needed. Though, these days there are case scenarios where, like, they sort of drive you through, so that, they give you a case scenario and you start working on it, and it's like an actual case scenario. So they can be combination and different kind of models which can work.
Thank you so much. One question for you. You mentioned quite a lot of layers to the healthcare system in which, intervention points, be it the patient, be it the child parent diet, or be it, NICU intervention point, or be it at home things that can be done. So, of all of these, maybe this question is to the other panelists as well. What would be the first priority intervention point in each of your opinions that different stakeholders can take? So, Dr. Neelam, I will get back to you after the last speaker's presentation, and when I open the floor, I hope all of the participants as well as the panelists can tell me what would be the one priority point for each one of you. And over to you, Dr. Priyanka. Thank you so much, Dr. Neelam.
Thank you so much, Team Dakshini, for giving me this opportunity. Pardon me for my voice, as I have cold. And I'm so blessed and lucky to be part of this panel discussion in presence of so many eminent faculty members. And how much I will speak, but I have learned surely a lot more from these discussions. So can you please start with the slideshow? Okay, is it full screen now? Okay, so today's topic of discussion from my end will be ensuring safety for, please go to the previous slide only. Yeah, so ensuring safety for every newborn with focus on strengthening of the healthcare systems to prevent harm and save lives in the critical hours after birth. Now, before I start with the topic, I would like to build on with few points like access to universal high quality healthcare system is the right of every newborn everywhere. Now, why I say this? Because the birth is a crucial period of transition from in utero dependent existence to ex utero independent existence. And effective care at birth is needed to anticipate any problems that may come during this transition and to provide adequate support and stabilization. So how can we achieve this? As already spoken by Sir and Ma'am previously, there are several health programs from Government of India and Ministry of Health and Family Welfare like Janani Suraksha Yojana and JSSY, which aims at 100% of institutional delivery, with current rate being 88.6. So we are aiming at 100% institutional delivery so that every delivery is attended by a skilled healthcare professional who is skilled at giving essential newborn care and provide neonatal resuscitation as and when needed. However, as far as the data is concerned, 90% of the newborn babies do not require any assistance in breathing. But there are only 10% of the babies who need assistance, some assistance in breathing, and only 1% of these babies will need intensive resuscitation. So with this background, we start. Please, next slide, please. So when a baby is born, what is the most crucial step? So as soon as the baby is born, the most important thing is establishment of the breathing. From there, only our NRP, as told previously by Neelam ma'am when she was speaking about birth asphyxia, neonatal resuscitation protocol. So establishment of breathing is the most crucial point of essential newborn care. So how do we achieve that? See, the immediate initial steps of newborn care involve securing a clear airway. So how can we maintain that? First, the proper positioning. We ensure the newborn's airway is open by gentle positioning of the head and neck in the neutral position, or it can be also in the sniffing position, as we say in the as it is mentioned in the NRP. And suppose any visible secretions that are there, the suctioning is not the routine thing. Any visible secretions, they can be cleaned using a sterile gauze piece. And if it is obstructing the airway, which is causing difficulty in initiation of breathing, then only suctioning is needed. The second important step or point of essential newborn care is prevention of hypothermia. Now, when we speak about hypothermia, the most important thing is that here comes the concept of warm chain. So what is this warm chain? The warm chain is basically, it is a set of 10 interlinked steps which is carried out at birth and just after to prevent hypothermia in every newborn. So basically, warm delivery room. We ensure that the delivery is taking place. The temperature of the room is between 26 to 28 degrees Celsius. Then warm resuscitation. Prior to every delivery that we take, there should be a newborn corner, and the radiant warmer is switched on a manual mode for at least 20 minutes so that the newborn receiving end is warm enough to receive the baby. And we have at least 2 pre-warm linens. Depending upon the gestation of the baby, we have at least 2 pre-warm linens in case of a term gestation, and one additional like a plastic sheet in case we are dealing with a preterm birth less than 34 weeks to prevent hypothermia. So warm resuscitation. Then in case the baby needs transportation to NICU, so there should be warm transportation. So like additional layering, transport incubator that can be used for that. Then immediate drying, skin to skin contact, breastfeeding, then postponing the bathing and weighing, adequate clothing and adequate bedding, putting baby and mother together, and training and the awareness raising of the healthcare provider. So these are basically the 10 steps which are very crucial to prevent hypothermia in newborn. In some of the babies where assistance of breathing is required, which we commonly call as initial steps. In that case, we can give gentle stimulation in the form of light tactile stimulation, such as rubbing over the back, and which can help initiate spontaneous breathing. And only, as I told you, only 1% of the babies need intensive resuscitation in the form of positive pressure ventilation, intubation, and maybe the medication. Now, what is EBGAR assessment? It is basically evaluation of baby's condition at birth by assessment of heart rate, respiration, muscle tone, reflex response, and skin color. But to start with the resuscitation process, we don't depend upon the EBGAR assessment because it is done at 1 minute of age. It starts soon after birth. The essential newborn care starts soon after the birth. Next slide, please. What are the other essential newborn care steps? Very important, delayed cord clamping. So why it is important? Because it allows, and first of all, what we mean by delayed cord clamping, the cord care plan should be discussed with the obstetrician prior the patient is taken in for the delivery, and all the babies who have spontaneous breathing and crying soon after the birth should undergo delayed cord clamping at least 1 to 3 minutes after birth, at least for 1 minute. And it allows continued blood flow from the placenta, which has various benefits, evidence-based benefits, both in term babies and preterm babies. Early initiation of breastfeeding. It is encouraged as soon as possible after the birth to support bonding and provide essential nutrients and antibodies. Eye care. Umbilical cord care, as highlighted by Neelam ma'am previously, the cord stump has to be kept clean and dry, and no application, practically no ointment or no sanitizer or no nothing has to be applied to the umbilical cord. recording of the vital measurement. This is all the part of essential newborn care, routine newborn screening, and initial vaccination. So when we are dealing with essential newborn care, the next another important step is prevention of infection. So again, previously highlighted the concept of clean C's. So clean hand, clean delivery surface, clean cord, clean cord cut, clean care, and clean perineum. So these all prevent the microbes entry to the neonate. So another aspect of how you can prevent infection is the initial vaccination. Newborns may receive critical vaccinations shortly after birth, such as hepatitis B and BCG and OPV, zero dose of OPV, and vitamin K injection is given to all the babies in the delivery room itself to prevent bleeding, to prevent hemorrhagic disease of the newborn. Next slide, please. So another important aspect is to identify those babies who need special care and may need referral to an ICU, or in case the delivery is happening at the community level, refer to a tertiary care center. So such groups include low birth weight babies and the preterm babies, and the babies who are and some other aspect that I'll be saying in the slide. So whenever the support is needed, we should be able to reach to an appropriate hospital or healthcare facility, obviously following proper transport protocol, and provide specialized care tailored to newborns' need. Care for sick newborns involve early identification of danger signs, be it at home or health facility, immediate referral to an appropriate healthcare facility, and help families access suitable hospital for treatment. So in special categories like the babies who are born to HIV positive mother, the facility should be able to provide preventive antiretroviral therapy to both mother and newborn, conduct early HIV testing, and ensure follow-up care of the exposed babies as per the guideline, and also very importantly offer counseling and support for feeding of the baby. So these are few danger signs which have been highlighted. Baby is not feeding well, the temperature is either too hot or too cold, baby is having abnormal body movements or no movement at all. There is jaundice and baby is ecteric till palms and soles, and there is severe respiratory distress in the form of chest indrawing or fast breathing. So any healthcare worker should be trained and should be able to identify these danger signs, either to take care of them at his own facility, or if the facility is not well equipped, then referral to the tertiary level facility with proper transport and proper care of the baby during the transport. Next slide, please. Now, first 24 hours is the most critical period, especially first 24 hours and the first 1 hour after the birth. So it is the highest risk for the newborn, as it was previously highlighted by Sumita ma'am, that most of the under 5 mortality is constituted by the neonatal mortality. Around 47% of under 5 mortality is constituted by neonatal mortality. And out of this 28 days, the first 24 hours are the most critical period. So every healthcare worker should be trained in providing essential newborn care and basic neonatal resuscitation protocol. So what are the leading causes of death? Again, it's the repetition from the previous talks. So the prematurity is the most common cause of neonatal death, followed by birth asphyxia and infection. And we have discussed in detail how it can be prevented and how it can be tackled at both community level, facility level, and at the institutional level. Timely interventions are very important, like immediate thermal care, skin to skin contact, breastfeeding within 1 hour of birth, mother's own milk is very, very, very important, clean delivery and cord care to prevent infection, and skilled birth attendance and rapid response to the complications. As per WHO, 2.3 million newborns died globally in 2022. The neonatal mortality rate has decreased from 37 to 17 per thousand live birth as per UNICEF data. And this I previously highlighted that 47% of all under 5 child death is constituted by the neonatal death. And so that is the critical time and why it is very important to be able to carry out essential newborn care so effectively. Next slide, please. So what is India's progress in reducing mortality rate? As per SRS 2020 and UN maternal mortality estimation interagency group. The progress from 2014 to 2020, IMR has reduced from 39 to 28 per thousand live births, and ma'am has given us the latest values of infant mortality rate to be 26, and NMR has reduced from 26 to 19 currently. Under 5 mortality rate has reduced from 45 to 30 currently, as per latest SRS data. And if we see in the form of long-term progress, MMR has declined by 83% in India against a global decline of 42%. NMR has declined by 65% in India against a global decline of 51%. IMR declined by 69% against a global decline of 55%. And under 5 mortality rate declined by 75% in India against a global decline of 58%. Next slide, please. So what are the key challenges that we face in newborn care? So the first thing is inadequate infrastructure. So many of the health facilities, they lack essential equipments and newborn care units. So our government is continuously working to various programs to meet, to be able to cope up this gap and meet and hopefully, and these numbers have been so nicely highlighted by Sir and Ma'am previously in their slides. So lack of skilled birth attendants, there is shortage of trained personnel to manage deliveries and provide immediate newborn care. There is sometimes delayed or inappropriate care in form of critical interventions being missed or not given on time. Then sometimes the poor referral systems, which is not well coordinated, can lead to delay in transferring the newborns to higher level care. And also the gaps in newborn monitoring. There can be inconsistent tracking of health indicators and danger signs in newborn. And if a healthcare provider is not well trained in identifying these danger signs, it can lead to gaps in newborn monitoring. Next slide, please. So what are the essential components of quality newborn care? So there should be a pool of skilled healthcare provider, trained personnel who are capable of performing safe deliveries, recognizing the danger sign, and providing immediate newborn care. There should be clean and equipped delivery room where there is availability of sterile instruments, proper lighting, functional resuscitation equipment is there so that at point of care, we don't face any problem. Then immediate care assessment and newborn care requires quick evaluation of breathing, heart rate, temperature, along with timely interventions such as resuscitation if needed. Early initiation of breastfeeding is very important and it should be well supported by the hospital staff, the doctors, and other trained healthcare professionals. Thermal protection and infection prevention, again, a very important aspect, which can be attained by skin-to-skin contact, warm environment. And there is, again, prevention to maintain asepsis, clean cord care, hand hygiene, and prevention of hypothermia, which is well associated with sepsis. So how can we strengthen the healthcare system for newborn care? So the important point is training and capacity building for the staff. There should be regular training programs to enhance the skill of healthcare workers in essential newborn care, how to respond in emergency situation, how to control infection, and to be able to identify the danger signs and ensure timely referral. There should be availability of essential equipments and supplies. This is important because whenever there is a consistent supply of neonatal resuscitation kits, warmers, clean delivery kits, medication, it will help us to manage newborn complications more easily. There should be standardized protocols for newborn care. There should be implementation of evidence-based clinical guidelines for immediate care. monitoring, and treatment of newborns across all healthcare levels. And there should be 24/7 emergency care and referral system. So that whenever there is a problem, the system can function to act accordingly. Functional round-the-clock services with efficient referral linkages to higher centers for timely and appropriate care of high-risk newborn will ensure timely institution of the treatment and intact neurodevelopment survival. Next slide, please. Thank you so much.
Thank you so much, ma'am. I think this was a wonderful revision of everything that we have gone through in the past 2 hours. So, ma'am, the same question to you. Of all the challenges and of all the different healthcare, good practices within the system that have been highlighted over and over by every speaker, in your opinion, what would be the topmost priority? One thing that should be targeted regardless of the institution?
See, when we are aiming at, newborn safety, very important part is that we ensure at every facility, be it PHC, CHC, district levels, or the facility or institution level, it is very important that every newborn delivery is at least attended by trained healthcare professionals, so that that person is able to provide essential newborn care. Because we are focusing on the critical 24 hours of life, but in those 24 hours, the first hour of life again becomes very important, and in those first hour of life, the first minute of life. So first minute of life, by the end of the first minute of life, the baby should be spontaneously breathing, have a heart rate of more than 100, and if not, then the PPV should have been initiated by that period of time, which is known as basic resuscitation. So this will lead to we are ensuring that the newborn will survive. We are not letting it to go into the asphyxia part. Okay, so this is very important. And second, why I told the first hour of life, because in those first hour of life, we are ensuring that the temperature part is managed. The baby is not cold. That we have prevented hypothermia, we have established breastfeeding, we have administered vitamin K, and we have made this important decision that this baby should either go to the postnatal ward or to a special newborn care unit. So this is what I feel is the topmost priority. It is very important.
Thank you so much, ma'am. Dr. Samita, Dr. Neelam, and Dr. Rajesh, opening the same question to you.
Yeah, actually, I agree totally with Dr. Priyanka, because I also wanted to say the same thing. That, yes, of course, preventive, promotive, everything has its own place in neonatal survival, neonatal safety. But ultimately, the most momentous point is during the delivery. And there lies our maximum challenge, because our facilities, however prepared they are, sometimes at that point they panic, they do something, they refer unnecessarily. So what I feel that at every level of facility, everyone should be able to handle a newborn normal delivery. And if there is any by any chance there is a asphyxiated baby born because of any reason, any complication arrives, I think they should have the skills, the normal resuscitation skills at every point. That is the most challenge which I faced, training people in neonatal resuscitation. But that is a must, because you never know when it is coming, in spite of all services and all. And there should be tele linkages, so that they don't panic, they just are guided, mentored, and there is a referral system in place for emergencies like that. I think that will be ultimately be able to make the dent on whatever remaining neonatal challenges are there.
Thank you so much, ma'am. Dr. Neelam, over to you.
Yes. Yeah, I agree with Dr. Ghosh and Priyanka that availability of a skilled health worker at the time of delivery. Because, like sometimes they say that, we can call a pediatrician, but if the pediatrician is not present at the time of delivery, or the health worker who knows how to resuscitate the baby, who has the skills, and also the infrastructure. I mean, like if you don't have a bag and mask which is working, or you don't have a laryngoscope, or you have a laryngoscope but you don't have the batteries. So they are small, small things. For receiving a baby, everything should be checked beforehand, from the sheet in which you're going to receive the baby to the surface, your overhead radiant warmer, your laryngoscope, everything, has to be in place. And, skills also have to be revived over the time, because many a time, as Priyanka very beautifully said that, the number of babies who require intubation or require active resuscitation would be very minuscule. Out of the 100 babies, maybe there may be only 10 babies who would require any form of resuscitation, maybe bag and mask, or maybe stimulation, or free flow oxygen. I mean, if you're not attending too many deliveries, your skills will go haywire. So periodically revisiting the neonatal resuscitation protocols or workshops is very important for all the health providers. And then, of course, doing an audit, seeing that, how many babies really had problems and what you did. Also knowing in reality what happened is also important.
So much, ma'am. So, quality control, updated skill set, and good infrastructure. I think these are the three main points that have come up so far. And Dr. Rajesh, over to you.
In the end, what happens between the healthcare team and the patient is the critical point. So we understand most lives can be saved, newborns, maternal and stillbirths, at the time of delivery, which is understood. Now, if there is no compliance to evidence-based guidance or practices which Government of India has laid through training packages, which is coming from WHO recommendations largely. So if we don't end up practicing that both in government sector, but also importantly in private sector, 40% deliveries probably still take place in India in private sector, where the government guidelines don't reach. So there it is assumed, it cannot be assumed that they are also offering good clinical quality of care. They may be offering good ambience, good, healthcare staff who may have good communication, surrounding may be clean. But what clinical treatment practices are happening, we are not sure. So therefore, it is important to continuously monitor whether compliance to evidence-based guidance is there or not, whether it is good quality and safe or not. And we had a lot of examples from, Neelam saying antibiotic stewardship. Similarly, oxygen stewardship is critical. Sometimes we just give IV fluids, oxygen, antibiotic because newborn has been admitted in the intensive care, which is not true, or it should not be. So inputs are there. Government has provided a lot of infrastructure, has improved. Health worker problem is there, but it has improved. But in the end, if they don't practice what actually is based on evidence, we will not be able to do much. So health system, the whole 6 blocks are important, and there is improvement through NHM. National Health Mission has done that, but practices profession has to and the government has to watch whether it is happening. And if your compliance is there, then point of care quality improvement happens. So PDSA cycle, after looking at the data, constantly, achieving compliance to evidence-based care will continuously improve the quality, and then therefore move on. More lives will be saved. Thank you.
Thank you so much, sir. Ria, over to you.
Yes, okay. Thank you so much, everyone, for joining. It is almost a 2.5 hours. So thank you so much, everyone, for giving time and joining. It was such a enriching and such a insightful discussion, and we look forward to your discussion in future. Thank you so much for joining. Thank you. Thank you.
Thank you so much.
Thank you. Thank you so much.